People becoming non-diabetic by using these?
You can reverse type 2 diabetes if you do the work.
This is Inside Out with James Catledge, another great show. I've got a great panel today. Our subject is anti-aging or longevity. And my panel is distinguished, and so we're going to try to get through some subjects that are curious to me, things that I'm thinking about as I get older, things that I know you're thinking about. To start off with, we've got Dr. JeffGross, a neurosurgeon. He considers himself a recovering neurosurgeon because he's moved his entire brilliant practice into longevity, stem cells, peptides, and the whole gamut.
That's right. Thanks for having me.
You bet. Welcome, Jeff. We've also got Josh Black and Janae Thomson, and they run a podcast. And I think you guys are based in Utah, right?
Kind of. So I'm based in Utah. Josh is based in Chicago.
Got it.
And we started the podcast in Utah. However, it is worldwide at this point.
Sure.
Just like your podcast is now.
Right.
So we are changing the world with this information.
And it's living younger, I believe, right? Is that what we call the podcast?
Becoming younger.
Becoming younger.
Becoming young.
Becoming young.
Yes,
Okay,
becoming
so they can
young.
find that wherever you get your podcast.
Wherever. Spotify, Apple, everywhere.
Great. Thanks for being here today. We're going to get into some of this stuff. I want to go through the list just to let the audience know the things that I'm curious about. I'm sure they are too. We're going to get into these GLP-1 drugs. The Wegovy's, the Ozempic, I think is maybe the most popular one. And we're going to talk a lot about that today because I think everybody's wondering, what's different here? Is this the same thing I could get in the pills in the supermarket? And why do I need a doctor? Why is it so expensive? These are the things they're thinking about. We're going to talk about HRV, which is, ultimately HRV is what's occurring between the heartbeats. Mm-hmm. And why is what happens between a heartbeat matter? But apparently it's a measurement of our health. Mm-hmm. And so we want to discuss that. And the other thing I think is really curious is this cold plunge. Everybody's buying one of these strange tubs to put in their house to get in this ice cold water. I still haven't done it yet.
I was just going to say, so you're saying you have not done that
yet, I have not
James.
done. I know Janae has it.
Oh
I've
goodness.
actually seen her cold plunge. and Doc, do you have one of these cold plunge
I
tubs?
don't, and it's a wonderful thing. I hope we get into it in detail, but I have to tell you before I get any further,
Yes.
it's cold.
Yes, it's very cold.
Yeah, right.
Very undesirable.
Very cold. Yeah, and it scares me that cold. I was having trouble when they were just putting the big igloo thermos with the cold water, pouring it on you. Getting in that, I don't know how I would do it. And then HIIT exercise. That apparently is an efficient way to exercise. So we're going to talk about that. I want to talk about how much sleep do I need. If I'm a pretty big exerciser, how much sleep do I need before I get back in the gym? And then this VO2 max. What is that, and how can I get mine measured? Another thing I don't have written down, but I know a lot of people are doing it, is these body scans. Mm-hmm. DEXA scan specifically.
Yep,
Well,
we just
Janae
got
and I
ours.
just got our DEXAs last week.
You did.
So,
So apparently
absolutely.
that's a premier scan to do, as opposed to the one where you hold the handles or step on the scale.
Mm-hmm.
DEXA is different, so we want to hear about that. Let's get into it. Tell me about, Doc, maybe we could start with you. Tell us about Ozempic, Wegovy, and maybe some of these others that are working off these GL1P receptors.
Right. So our body processes sugar, and it's sugars everywhere. It's too much everywhere, right?
Right.
And when we process sugar, we take it in through our foods, through carbs. Dare I say that dirty word?
Our favorites.
Right?
They do taste good. Then we respond by secreting insulin, and if we're wonderfully sensitive, it handles the glucose, it drives it into our cells where it's utilized, because that's the fuel for our cells, and then it's disposed of, and we go about our day. But you're exposed to too much of this sugar. It is an inflammatory toxin. We were not designed to be exposed to so much sugar. We were designed to be exposed to complex carbohydrates, if that. Because we really are protein-fixing animals. We need our protein, and often protein comes with some carbs.
Can I ask a question about how much sugar? You say we do pretty well with a little bit of sugar. What is too much? Where do we reach that threshold?
Well, it's different with different people, and it's because of that insulin sensitivity or loss of sensitivity, which is called insulin resistance. And you can start to see the pattern with how people look. Usually insulin resistant people carry more weight.
Got it.
That weight is centrally deposited, typically around the middle of their bodies. And they have trouble losing weight, they have trouble putting on muscle, and they have all kinds of accumulated other metabolic problems
This
as
is
a
an
result.
insulin-related issue. This is insulin.
Right, stemming from response to sugar.
Got it.
So going back, how much sugar do we need? We probably don't need any refined sugar.
Okay.
The closest thing we would ever need to refined sugars is processing fruit.
Okay.
Fruit has fructose, which is one molecule away from glucose, which is table sugar.
Right.
We really weren't designed for glucose, and fructose should be limited. Fruits were probably a very special treat, hundreds of years ago and thousands of years ago.
Like a dessert. Yeah.
Right. And you were lucky to find a piece, anywhere.
Right.
So, we really were designed to process protein.
Okay.
So the problem here is our bodies can't keep up with the sugar. And as a result, we have a population that's metabolically messed up, metabolically deranged, and I call it metabolic syndrome.
Okay.
Which is silly. It's just,
This
it's
is
way
diabetes.
too much.
You're referring to diabetes.
Well, diabetes is the first part of that, but then you also have what goes with that could be your fats are out of order, your triglycerides and other labs and things like that.
Okay.
So it goes downhill. But you're right, diabetes is insulin resistance in its disease form. You just cannot respond to the sugar. Your sugars go too high, and then you get toxic exposure to the sugar. You lose your kidneys, you lose your eyes, you lose your nerve function.
Wow.
Anyway, back to your question.
Ozempic and Wegovy.
So it is a hack. It is a biohack.
Okay.
That certain molecules in our body with yin yang and a lot of things in our bodies have on and off, and they play against each other.
Okay.
Like sleep and awakeness.
Yeah.
Right.
Yeah.
So the opposite of insulin is called glucagon, and if you can take advantage of glucagon receptors on the cell membrane, you can blunt some of this problem with the insulin and the glucose.
Okay.
And to do that, you can either be given glucagon after each meal, which is very difficult. It'd have to be done intravenous, probably.
Okay.
Or you can use a small peptide, which is a few amino acids strung together strategically, that binds the glucagon receptor. So it's glucagon-like, but it's not glucagon. That's the G and the L of GLP.
Okay.
And the P is peptide.
Okay.
Glucagon-like peptide 1 is a particular receptor that's bound and stays bound for a long period of time, like hours or days.
Okay.
And in doing so, your cells just don't get that toxic sugar exposure as much.
Why?
Because the glucagon won't let it in.
It's blocking it.
It shuts off the ability to bring in the glucose through the transporter mechanisms where glucose goes into a cell. So it gets passed through you and also has other effects that slow down motility in your GI tract.
Where I feel full.
You feel full, so you're probably less hungry.
Yeah.
And
I'll eat less.
You may even have a little tummy ache if you're full all the time, and that also is a reason not to be appetized, right? So for all these reasons, and also now we've learned there's something about the peptide that deals with the satiety center. I feel comfortably full, satiated.
Yeah.
So through these mechanisms, GLP has been this wonderful biohack.
Wow.
And it's a peptide. And I know we're going to talk about peptides as we get into this. It is a peptide.
Okay.
But insulin's a peptide. Melatonin is a peptide.
Am I taking this by injection, doctor?
Yeah. If you want it to work.
Okay.
Yes. Now they do make a troche form, which is a dissolvable for the mouth.
Okay.
You have to do that one daily.
Under your tongue?
Under your tongue.
Okay.
And the injectable is subcutaneous, just under the skin.
Yeah,
and
in a fat part of your body.
Yeah, if you have one. And then it's
right. I'll have to look.
It's and it's weekly, and I gotta tell you, it's we have had almost complete success with people.
Weekly.
Yeah, it's amazing. You do have to bring up the dose because you adjust to it.
You've clinically seen this effective.
I'm not only an owner of a practice that uses it. I am also a customer.
A user.
Right.
Which one are you using, if you don't mind me asking? Ozempic or?
Yeah, so the generic first line is called semaglutide, which Ozempic is the brand name. It's the least expensive and more readily available form.
Okay.
The next one up that has a couple different mechanisms on receptors is called tirzepatide, or Mounjaro might be.
Right, Mounjaro. I've heard of that one, and apparently you lose more weight with Mounjaro than you do Ozempic.
Probably across the board when you look at populations, but we have individuals that do differently on.
Interesting.
And you should know that there's a third one coming that actually has 3 mechanisms that they have in Europe that we're going to be having shortly.
Can we talk about what the second and third are? You did a good job of the first, the GLP-1. What is the second receptor and third receptor?
They're also GLP-1 like, but they're different, has a combination of different peptides that work more robustly.
I see.
Yeah.
So like doubling down or belt and suspenders.
Correct.
Okay. Why is this different than fen-phen?
Well, fen-phen's a stimulant. Phentermine stimulates the heart. It increases metabolism, like the good old ephedrine-based Dexatrim back in the day.
Sure,
Remember those?
Dexatrim, yeah.
But it worked like crazy, except
Yeah.
the cardiac complications were dangerous. So, and phentermine can have that too. It raises your heart rate, and it does raise your blood pressure. And if you're not healthy or at risk, you could have a problem.
So you're saying that Wegovy, Mounjaro, Ozempic, these are not fads, these are not trends, these are not gimmicky at all, but they're doing some work internally that needs to be done.
They're only a fad right now because they're working and they're on social media, but they work. They're
working.
Medically justifiable. And
Boy,
also,
that's good to hear.
Also, the anti-inflammatory benefits and anti-aging benefits.
I was going to say there's some other research that's coming up now showing that there are much longer term benefits to
What
the
are those,
GLPs.
Josh? What are those benefits?
Well, they're not really quite sure what it actually is happening, but they're seeing that there is additional health benefit that is in addition to just losing the weight, right? Just keeping that up. You probably have read some stuff that I haven't.
No, you're spot on. That's exactly what I've understood. And this is sort of as we have more accumulated years of experience and more accumulated numbers of patients, we can look back longitudinally and understand
why it's
what
working.
those additional anti-inflammatory / anti-aging benefits are.
Correlative, causative.
Yeah.
Right. It's hard to know.
Yeah. And are people becoming non-diabetic by using these?
Right, you can reverse type 2 diabetes if you do the work. So,
what percentage of the population do you believe could benefit from these drugs?
At least 50-60%.
Wow.
I would agree.
Yeah.
Okay.
Based on the numbers I've seen.
That's significant. So does that affect the space you're in? I mean, it sounds to me like if I lost 20% of my body weight, I'd be very interested in other longevity techniques. Let's get into some of those. You've done an amazing job helping me understand Ozempic and why it works. I literally thought it's just an injectable form of what you could get at the grocery store, but this is so much bigger.
Well, and these are some really great benefits. And a couple questions I'd love to ask you as the doctor is a couple risks and side effects, right? Because I think those are important to address as well.
Great,
so
Janae.
when you talked about how it slows down digestion and it affects the satiety feeling, which is a good feeling because then you're eating less, but as it's slowing down the digestion, is it affecting the digestive system in a way that's allowing the food to not digest properly? So that's my first
Great
question.
question.
well, the longer the food is churning in the stomach and then the intestines, it has a better chance to digest. The problem is at some point you do like things to move through your system at a good pace. Otherwise, by the time it gets to your lower intestine, it's mostly toxic waste, and then you want that to be evacuated, and it's very slow. So you really have to focus on mitigating that ahead of time with good probiotics and prebiotics and exercise and fiber, which we will throw that in the prebiotic group. But all these things will help mitigate that, and really that's the only thing I have seen with my patients and myself is the slowdown in things moving through. I haven't seen any other risks. There are, of course, always the risk that someone won't tolerate it for another reason, have a strange reaction. I've never seen it, but I do.
Like what's a strange reaction? Nausea? Gastrointestinal issues?
No, I would call that a normal reaction. I think you should expect some of that, especially at the beginning.
Okay.
But like anyone can have an allergic response or an adverse response, which is sort of vague. We never know what it is.
Right.
And it's important that we have these kind of conversations.
Yeah.
When Ozempic got huge, right, there was a New York Times article where they highlighted several folks that had, I think it was intestinal paralysis or something like that,
oh, gosh.
right?
Yeah.
And so, some was in the hospital and they were in the ICU and all this stuff. And so,
and their system didn't work.
Right. And so things happen, right? But I think it's important to highlight that is not
these are anomalies.
Typical.
Yeah,
right? That was over dramatized.
Yes.
This whole concept of paralysis, slowing down of the gut, even severely, isn't paralysis. That was misused and it caused this.
It's the wrong
fervor.
word.
Yes.
Yeah, I think that was improper.
But this is also where, you're saying the probiotics, this is a preventative thing to help with that. Also probably a diet high in fiber would help, right?
Yes.
And so there's lots of things, making sure your water intake is high, making sure your high fiber diet, probably sleeping well.
Well, now we're going to open the whole gambit of anti-aging.
I don't want to go down that one, but
yes.
these are all the main points of how to optimize these tools that we have to use. And that's kind of one of the things that Josh and I love to address on our podcast is, there's all these amazing tools, but what percentage do they affect if you're not doing the basics first, right? The basics, healthy diet, high activity, sleep, right?
So you're right. A lot of people take Ozempic and don't do the other work. And they still lose the weight, and they start to look good and feel better, but they're not going to live, that much longer if they're really having a longevity, health span attitude. Mm-hmm. You're right. They have to check all the boxes that they can do with, the whole epigenetic lifestyle factors that affect, are we degenerating, and if so, how fast?
Right. And muscle ability, the muscle structure that you have is the most important factor within your activity, right? And so Ozempic or things like this, how are they affecting muscles muscle structure?
That is a perfect question, because there is some muscle loss when you lose, just like when you eat protein, you're going to get some carbs with it. Well, when you lose carbs, you're going to lose some protein with it. You're going to lose some of that. So you have to really exercise, and you have to eat protein.
Right.
You have to eat good protein and good amounts of protein. A rule of thumb might be 1.8 to 1 gram per lean body mass. That means if you're overweight, you don't count the overweight part, which it's where you should be.
Right. Okay.
So that's how you measure the protein quantity per day. You take the lean body mass, and then you put 1 ounce of protein per pound.
1 gram.
1 gram
per pound
of lean body.
Right.
All right. So let's say I'm really overweight. How do I know my lean body? Do I need to do this DEXA scan?
You go with your goal rate. You start your goal weight.
Oh, very good.
And then you say, okay, my lean body, my lean part of that should be about 70-80% of that, perhaps. Mm-hmm. And there are tables. You could plug this into the internet on a basic calculator they have. Yeah.
Or most guys could probably reference back to their high school weight. That's probably pretty close, right?
That's pretty good too. Yeah.
That's good.
But if you want to gain weight, if you want to gain muscle, you need even a little bit extra.
Yeah.
Okay.
And you do need some carbs. If you want to put on muscle, you do need carbs. You're going to burn those. So I'm not saying carbs are the complete enemy in all cases, but the
protein.
right carbs.
But so I'm also hearing with this, when you're using this as a tool, it's really important to be aware of your protein intake as well.
It is, and it's good to track it. At least, I have some people who have no idea. So track it for a week. It doesn't have to be this, hardship. Track it for a week, and then, a couple months later, track it again and see where you are.
But this is also something that's very important as you age in general, right? Because you're losing that muscle mass every decade once you hit basically 40, right? Although there's some new data now showing, again, is it causative or correlative?
And it's 40 and 60 where those
slowing
points
down is
happen.
why you're losing the muscle.
Yes.
Right.
So, but it is so important for you to have, regardless of whether you're using a GLP-1 inhibitor or not, to make sure you have that protein to keep that muscle on while you're active.
Let's talk about muscle for a second, because I've read articles lately that say, and Janae was hitting on it, that muscle mass, muscle quantity is the single most important thing you can do for longevity. Is that true, and do you guys buy into that?
I believe it's true for a number of reasons, right?
What are those reasons?
Think about just mobility,
Okay,
right?
sure.
So keeping yourself upright.
Or if I fall.
If you fall, right,
you have more muscular structure to support your fall.
It could prevent a fall.
Right.
It could prevent a fall.
It could prevent a fall.
Right.
You also have, we talked about insulin, you have insulin receptors in your muscle.
Okay.
Right? So the more muscle you have, the more insulin receptors you have.
Got it.
That is going to really help keep that blood sugar in check as you get older, right?
Okay.
So even if your body's getting a little lazier with its sensitivity,
right,
you want to have those receptors around.
So the best way to put on muscle is it's the old tried and true. You got to get to the gym and you got to lift weights. I mean, what is the muscle building? What's the most efficient source to build the muscle?
Well, that's a really good question, and I have some experience as a personal trainer in another life.
Okay.
And what happens, so you can go to the gym, you can lift heavy, but if you're not actually tearing the muscle, it's not going to break down. So if you're not doing the proper amount of reps for the proper amount of time and feel the burn and build the lactic acid, then the muscle's not going to tear enough to rebuild.
Oh, okay.
And so it is a certain formula, right? But it also... yes, you have to get in there and do it, but then there's also a formula to it.
Got it.
If you're not following that, if you're just going and running on the treadmill, that's not going to build muscle
cardio,
for you.
really. So you're saying I need to tear the muscle,
right?
in
and you
order
can feel
to build
that
it
within your workout. You know, it's like, okay, you're lifting, and you're like, I have to do 10 reps, and you do your 10 reps, and you're not feeling a burn.
Yeah.
You're not building the muscle.
Okay.
And so there's a certain
point. When you say feel the burn, you mean I'm getting tired?
Right.
Like I can't quite lift it?
Yeah, and once you get to the point, and I'm not promoting over strenuous exercise where you're going to hurt yourself. So this is, again, a fine balance.
Okay.
But, once you think you can't do any more reps, that's when you do 2 or 3 more or
and
one
I'm
more.
Tearing.
And then you're tearing the muscle. Now you're not tearing within your body, so I don't want to. Micro tears.
Yeah.
And you want to be very careful not to produce injury within this.
We're not ligaments and tendons. We're talking about that muscle fiber.
That's a different kind of pain, right? That's painful pain. Where this is just like, I want to stop, but then you keep going. That creates the micro tears.
I think a lot of folks. So I belong to a racket club, right?
Yes,
so I'm constantly playing paddle and pickle and tennis
racquetball.
With guys who are 50, 60, 70 years old,
That's right.
And a lot of those guys go to the gym.
Yeah.
And they tell me, they say, well, I'm going to the gym, but I did some light lifting, right? And I'm like, that's not going to get you what you think what you want, right?
Yeah.
You need to be lifting heavy. You need to be challenging yourself. Just with, we're going to talk about all kinds of different things today, right? And if you notice, a lot of the things that are common throughout the thread with these are they're a little hard,
it's
right?
It's hard to do.
It's hard, and so that difficulty. Gives you results on the other side, right? No pain, no gain, right? And so you need to be lifting heavy. I'm in a building phase right now, right? So I go to the gym 4 days a week. I'm lifting. I'm doing. I think I do 64 reps in every one of my circuits.
So that's creating a lot of micro tears.
I got lots of burn. I am barely able to walk to my car. Right? I'm not hurting myself. Right?
It'll restore tomorrow.
I'll feel great. I'll feel great tomorrow. Maybe a little tired, but I'm building that muscle.
And another good indicator of that is if you're sore the next day. If you have soreness and you experience that muscle soreness in the muscles you worked, then you created those micro tears.
So that soreness is not lactic acid per se.
Well, it is a buildup of that residually from the workout.
Is the lactic acid chasing into the tear? Is that why I feel the lactic acid?
That's a great question.
That is a great question.
I don't know the answer to that.
What's happening?
Well, I'm glad you clarified the micro tears. We're not trying to hurt anyone.
No, right.
But the lactic acid, it would be something you would feel in the initial minutes during and after the exercise. Lactic acid is a molecule that is not, it's lactate, and it easily goes in and out of our cellular cycles.
Because your body wants to clear it out almost immediately, right?
But it also uses that as a fuel. The brain actually does pretty well on lactate.
It's very efficient.
If you ever notice this, you exercise well, later in the day, your brain works better. Do you ever notice that?
That's why they call it the best antidepressant, right?
It is the best.
One of the
but
best.
Wait, there's more. The muscles, when you use them, release a peptide. I'm going to circle back to that. They're called myokines. Myo for muscle. Kines means to like or to be affiliated with. So myokines are probably the best way to stimulate the brain to help prevent dementia, the formation of inflammation in the brain and dementia. So muscle maintenance is not only good for longevity and health span, it's good for the brain span. So I get to wear my neurosurgery hat just for a minute there.
Yeah, that's
Which ties in directly to how well you live through those years as you progress in age. Because if your brain doesn't work, even if your body's working, you're not going to have the health span, brain span that you're just bringing into this.
100%.
How do we increase the as you call it, the myokines? You don't sell these. These are something you've got to produce. Right?
These are in your body.
These are in his website.
As we talk about peptides, they probably will be an injectable form of myokines come up, and it may be a drug type target, a peptide drug target for people who are developing, Alzheimer's, dementias, and things like that. But you want to get the most out of your weight-bearing exercise. Okay. I'm talking to people who know this better than me, possibly, by getting the muscles, and you need the right exercise. We're going to talk about HIIT and working to failure, because the best secretion of myokines comes right at that last rep that you can't finish. And
where it's like you want to be done, but that's when you push yourself to one or two more, and that's when you get that growth.
So this is when the myokine shows up.
And then you're sorer, which is that feeling you need to get. And wait, there's more. The entire you can get there by biohacking. There are ways to get there, and some people will do one set to failure as opposed to 3 sets of 10 working towards a max. There's even something called VASPER, or you guys know about this, right? Where you actually put tourniquets on the extremities.
Wow!
And in a shorter workout, you can get to failure quicker by taking the blood flow and the oxygen away.
Resisting the blood flow.
Yeah, and you're stimulating the survival
you
mechanism.
You want to be very careful with this concept.
Yeah, just of the extremities.
Sure.
And survival mechanism of the muscle to release the myokines.
Don't cut around
the throat is usually not the best spot for this.
I mean, my kids think that's a really fun game, and I'm like, no, you cannot do this.
No.
They're like, but it feels great.
So
goodness. Let's be really specific here.
Yeah, that's great. Great, thank you. That's good.
Sorry.
So let's talk about HIIT exercise for a minute.
Okay, I would like to ask the doctor one more question about the Ozempic, and then I want to do the HIIT. So you were talking about the blood glucose levels. And, obviously when you have this, the insulin comes in, and then when there's so much sugar coming in all the time, you can get either type 2 diabetes, or it just turns into metabolic syndrome. So this isn't something just affecting diabetics anymore. This is something that is coming into more of the general population, and this higher rates of insulin that your body's naturally producing, and it's causing the degrading of your organs, like you were saying, kidneys, these things that kind of used to be problems with diabetics, their organs, they'd have eye issues, they'd have kidney issues. So my question is, with the Ozempic and these other things that you're using, is it preventing that blood glucose from getting high enough that the insulin is coming again and creating almost protection from that degrading in the organs?
I think so. I don't know that we have enough to look at this. And just so we're all clear, the glucose goes up, the insulin goes up, it drives the glucose down.
Right.
When we become less sensitive, the glucose goes up, but then the insulin doesn't. That's called insulin resistance. That's the pre-diabetes to diabetes to metabolic syndrome. So we like insulin.
Right.
In fact, type 1 diabetics who are born with can't make the insulin or make enough of it, that shows you it's the low insulin. We need, if we could have better insulin sensitivity, we may not need all these things. But I think the less sugar we're exposed to is like the less poison you're exposed to.
Right. And that's really what I'm getting at, is like that's the underlying concept, right? And so that's the goal that we want to have, whether we're using these tools or not, but that's a healthy lifestyle choice. But also, as sugar's affecting the body because we're eating way too much of it just in general, okay, we can cut back, but then also, is this a tool to help with that?
Yeah, I think it is a tool. I think you asked earlier, is it preventative? Yeah, I think so. I mean, if we start this earlier on people who have some predilection or risk factor or need, I think we are going to see that. We don't have those results in front of me because they don't exist yet. But I think we will learn that. I think your prediction is correct.
Okay, cool.
So if I understand, you're guessing that, and maybe forecasting, that these GLP-1 drugs could be preventative prior to someone becoming obese and may be more effective. You're just waiting for the data for that.
I think it's more effective just to have a healthier food source and change what's in our food source and reduce the amount of sugar or simple carbs. That's easier.
Sure.
Why can't we just do
that? And
that?
that's the most healthy path.
Right.
Yeah. But you are saying that if I have a predetermination to obesity. Maybe it's in my family. Maybe everyone in my family's large. That maybe giving this to a young adult prior to them being obese could be very helpful.
Yes. Oh, absolutely.
Wow. Okay. Let's shift into HIIT, guys.
My favorite topic.
Yeah. Tell me why HIIT is more efficient than other exercises.
Well, okay, so for me...
And is it more efficient than other exercises?
Well, I fully believe, yes, it is. Now, it's also got to be a part of an overall health and fitness plan.
Okay.
So I'm a single mom. I have 4 kids.
Right.
When I go to the gym, I need that time to be the most efficient possible. So that's my typical go-to workout in general, is a HIIT workout.
What does HIIT stand for?
High intensity interval training.
Got it. Okay.
So you're doing high intensity, so you're getting more of that really heavy weight or high intensity cardio, depending on what your goal is. You're
and
doing
I measure this by heart rate?
No, not necessarily, because if you're doing a high intensity resistance training workout, you're using heavier weight for less reps.
Okay.
Right. So you're condensing the weight. So let's just say instead of using 10 pounds over 20 reps, that's what 200 pounds.
Use 20.
You're using 20 pounds over 10 reps. It's still 200 pounds. And you can use those ratios with whatever your numbers are. That's just an example. But this creates more time efficiency in your workout. So for someone like me, when it's, are you going to go to the gym and spend an hour or two? I mean, Josh has that kind of time.
Yes.
Sometimes.
Yes, yeah.
I don't generally. And so if it's the difference between I go to the gym and get a workout.
Yeah.
I love to spend time doing things slower if I can, but if I don't, this is
if you have an hour,
the highest efficient time-wise way to get a workout in.
Yeah, but I so
now Josh is gonna. Here we go.
I think it's really great, but it's an and. It's not an or.
Okay.
So you have to think, and we're going to talk about the VO2 max later on.
Yes,
but
I think we cover it next.
This is direct correlation, right?
Yeah.
So if you think about your longevity fitness pyramid, right? You want the biggest pyramid possible, right, with the tallest peak. But the only way to get that peak is to have a wide base.
Okay.
So HIIT is awesome, and it does all kinds of really cool things, right? And the data that we have, that is even new data that's come out in the last year or two, is showing that there is significant longevity benefit just in those 10, 12-minute HIIT training. And a lot of that is running, cycling, things of that nature to really get that heart rate really up and to really push the cardio, because it's the VO2 max, right?
Yeah, right.
But all the data, right, if we go to VO2 max, right, which is a good overall indicator of health, right? Because you can't be unhealthy and have a high VO2 max.
Is VO2 max my ability to get oxygen to my muscles?
It is. It's basically the size of your engine.
Okay.
Right.
Okay, so you're measuring the quality of my engine with VO2 max.
It's how many milliliters? How many milliliters of oxygen that you are getting into
my
your
muscles.
Yes.
How do they measure that?
So there's a couple different ways, right? We obviously have watches, so
the Apple Watch,
the Apple Watch, the
Oura
Whoop,
Ring,
Oura Rings.
Of course.
I would say those are directionally accurate.
Okay.
I mean, my feeling on consumer wearables is that they're close enough for the general population.
Yeah, I got it. Yeah.
You can also kind of establish a baseline, whether or not it's accurate. You can establish an accuracy within the ranges on these.
Directional.
And there are two other ways that you can do that, right? So the other way is to go to some place like one of these
DEXA scan places.
Yeah. They will for $100 put you on a treadmill, give you a mask, and actually measure
That's
the
an accurate
CO2.
Number.
Right. That's probably the most accurate way to measure.
Okay. What is a good VO2 max?
So most folks fall probably on the bottom half of the spectrum. So I like to think of myself as an elite longevity guy, right?
That's why you're here.
That's why I'm here.
Right.
But the way that I am looking at myself is not the way that I would look at necessarily the general population.
Okay.
Right? And the people that I coach aren't necessarily spending the same time that I'm spending.
Developing your VO2 max.
The only way that you can get a high VO2 max is spending time, right? There is no shortcut for really developing VO2 max.
And that's why that number matters.
It does.
Because there's no way to hack it. There's no peptide for it.
Well, myokines are coming. Hang in there.
Yeah, right. We're not there yet.
Thank you, doctor.
There's no subcutaneous injection for VO2 max.
But the short answer is, for me, on longevity, minimum is between 48 and 50.
Okay.
Right? I personally shoot for 60.
Got it.
Right?
That's a VO2 max number.
That is the, yes.
What is the 60 measure? What is the 60?
That is the, what is it? Is it milliliters per second, right? I think so.
So it's milliliters of oxygen being delivered to the muscle.
Yes.
Wow. Is it the number being delivered to all muscles simultaneously, or the muscles being used?
Yeah, all muscle. So it's just what you're putting out.
Got it. Okay. So what is what would you say the average American's VO2 is?
I think I'm
25?
I'm trying to remember what the bottom quartile is. I think it's somewhere between 25 and 30, if I remember correctly. I don't have the numbers in front of me.
All right. So if my little Apple Watch is showing me 25,
you got some work to do.
I got issues. I need to renew my membership. Okay. So 60 sounds high to me. What would be a Lance Armstrong in his heyday?
Lance, I think, is somewhere in the 80s.
Whoa.
Wow.
Okay.
So or higher.
It could be higher. So what's the scale go to? 100?
I think so. There have been some elite athletes that are at 100 or 110.
So it goes above 100?
Yeah.
My goodness. Okay.
There's a fantastic sports scientist, and I don't recall his name, out of Finland, I believe, who does a lot of this hacking with Olympic athletes. And he basically, they are dialing in the VO2 max.
Okay.
So they are constantly measuring to see how efficient they can get them, because there is a point of diminishing return, right?
Sure.
It has to do with how much muscle mass you have. It has to do with how trained your red blood cells are. There's all of these...
Lung size and how you stretch the chest cavity. All
the way you breathe, the way you bring in the air.
Yes.
Do you use the nose? Okay, question. This is for all of you. I noticed, because I'm an Orange Theory guy, and I think I just crossed 1,300 classes, so I've been doing it a while.
That's great.
I have no idea what VO2 max is, but I hope it's above 25. I notice that literally in these Orange Theory classes, there are folks in there who literally can't do one of the exercises but can do the others, and is there a reason for this type of thing? For instance, and these are people that look to be in shape, like they'll go from the treadmill to the rower, and then the rower they just can't quite function on the rower, they just can't quite get it, and then they go to the weights and they can do it, but the form's off, the balance is off, and they've been there a long time. What do we attribute this to?
Well, I have an opinion. I have an opinion on most things. So
Yes.
I'll tell you what my opinion.
Yeah.
So I have been working out for many years. I started training with a group in Chicago that does triathletes, Ironmen, all this kind of stuff.
Yeah, good.
Right?
Yeah.
And so I kind of had my own personal training program that I had put together. And when I went in there, I realized it was totally wrong. Right?
Okay. Yeah.
And I wasn't balanced. I wasn't balanced left to right. I wasn't balanced top to bottom. And I wasn't balanced front to back.
Okay.
And part of what I actually experienced was getting on the rower and not being able to row well.
Yes.
Right? And it's because I had overdeveloped some of my front muscles. I had underdeveloped some of those back. So after I had spent some time, going through a program that was a little bit more comprehensive to get myself balanced properly, that totally went away.
Okay, so that's probably exactly what it is. Why are some people able to not use their mouth to breathe in deeply, only use their nose, and others are mouth breathing through these heavy HIIT type efficient workouts? It doesn't matter. Are you getting air wherever you can get it, or is there a preferred way for someone exercising?
That's a great question. I don't know that
I
don't
mean,
have the answer.
that might be a doctor
I could
question.
take a little trip into this, but the nose is the most efficient method of breathing because it humidifies the air on the way in, which is good for us. It's either
Is there a filtration system there?
And it's a countercurrent multiplier, which means it warms the air. Well, unless it's already warm, and it moistens the air, and then on the way out, it takes that moisture back out and cools the air. So it's kind of a cool system.
Interesting. So if I notice people tape their mouth to both sleep and exercise. The elite athletes are taped up. So is this what's happening? They're forcing the nose pathway.
Yeah. Now, a lot of people have, or over the years, nasal, obstructions, deviated septums, and when you're at the sprint at the end, you have to open your mouth to get to gasp, and there's a lot of anatomic problems. If you talk to anesthesiologists who put people to sleep for surgery, they can tell you all about the shape of the airway and the size of the mouth and how much air you can move through that size of the pipe.
Got it.
So there are
that
limitations.
would be important in this efficiency fellow who's busy with the VO2 max and the dialing in. He's probably aware of these pathways. And
I'm sure
you're capable. I'm not. So we've got to dial you in differently. Right. Yeah, you can be taped up. I can't.
Yeah.
Right. Yeah, because I noticed they sell tape on Amazon and even at REI for fitness people, and I'm thinking,
and for sleep,
looks
for
like,
sleep, James, for
dangerous.
sleep, people use it at sleep. It helps you, your
just
brain
get deeper breathing.
And it supports the more restorative, deeper sleeps, the type of brain waveforms you want to get for the restoration during the night, during our repair phase.
So nothing through my mouth matters in sleep. Meaning I could shut it down and the nose would give me everything I need.
It's supposed to, unless there's a reason otherwise. Which takes us back to our first conversation.
Yeah.
Less in here.
Yeah.
Helps,
We're talking about
and
food
less,
as well.
less air, less food.
Right.
So your
Less
mouth
sugar.
is the problem. It gets you in trouble.
Get it shut down. Tape
And
it up.
it can definitely get you in trouble, but
We know
depending
that.
on what comes out of it, your words.
That's right.
Exactly.
So that's interesting. So if I did tape it up, the nose really would be better for me.
Yeah, again, as long as you can move the air. Yeah.
And this is also where you need to be aware of your anatomical positioning of the nose, any injuries, like the doctor was saying, there can be issues with that. So,
in case
it's
you
very
get partial
individual.
air, it may be dangerous.
Right, and your neck position, how your trachea is at night, if it's sleep related, if it's exercise related.
My back.
Yeah.
Yeah, versus the side.
They're all factors.
Right. Is there a preferred way to sleep?
I mean, I have my preferred way. I would like to know if there's an actual best way to sleep.
Yeah. Is there a preferred way to sleep?
My chiropractor tells me however you're comfortable.
Interesting.
I would like to hear what the doctor has to say on this.
What is the preferred way to sleep?
Listen, your body will move and find its place the way it wants to at night and in its most comfortable spot. So I kind of agree.
Yeah.
If you think about it, if you lay in the same position all night long without moving, you will get a pressure sore. You could have problems. Your body moves around at night, so it doesn't get those.
Yes.
But if you look back, you ever seen some of these nerve sharks, and you ever seen on some Jacques Cousteau, documentary? You turn the shark belly up, and they go to sleep. They go catatonic. So it's probably our way our brains and inner ears work is we probably become more sedate and relaxed and go to sleep on our back. We probably don't end up there.
So you would say, as a neurosurgeon, there isn't a preferred way.
I don't know if there's a preferred way. A sleep specialist may correct me.
Okay. All right. We'll leave that open to another episode. Sleep specialty. So guys, I really need to understand this senescent cell. And am I saying it correctly?
You are.
These are, as I understand it, dead cells that the body is attempting to slough off, or they are near dead. Is that right?
They're zombie cells.
Okay.
Right? So
they're not being used.
Correct.
They were used.
They're in a dormant state because something is amiss.
Okay. Can they be reactivated?
Probably not.
They're gone.
Let's look at them in a slightly different way, if that's okay. Senescent cells are still living and sucking up our resources.
Oh.
Taking them away from youthful and more functional optimized cells.
Okay.
Which is a problem and a drain on the body.
So it's truly ideal to try and get rid of them.
You want to get rid of them through a process, either where they explode and die, or they are recycled. That's called autophagy.
Okay.
Which is the better way to do it. And autophagy is best done through hormesis. And you alluded to this earlier, cold plunge, HIIT exercise.
I was hoping you were going to say that was a joke and nobody should be doing that.
Yeah.
But that's not true. Okay.
Hot sauna. I mean, these are slight stresses on the body that build resilience.
Oh.
And they build that by helping you clear out. And the best, easiest way you can do it is just fasting. And I say it's easy, but I mean, a good old 72-hour fast will reset your immune system because it's killing off a bunch of senescent cells.
Okay.
And it also, senescent cells are more likely to form cancer. So if you fast, you help prevent cancer.
Interesting.
Yeah, but you don't want to do that 72-hour fast too often, otherwise you're going to lose your muscle mass, which then causes another problem over here, right? So it is a balance.
That's fair. Don't do it every 3 days.
Right.
What is the frequency of fasting that would be ideal for someone trying to really elongate their life and be healthy?
I mean, ideally, a 72-hour fast every quarter and intermittent feeding are probably enough.
And when you say intermittent feeding, we eat within a 10-hour range. What's intermittent feeding?
Yeah, I mean, some people call this intermittent fasting, which is sort of silly because we're not supposed to eat while we sleep.
Sure.
We're not supposed to eat in the dark, actually, is how it works. So,
Okay.
so
I'll stop doing that.
So once it gets dark, you're done eating.
All right.
and
Note to self.
TV screen does not.
Right.
That's not light.
Right, that's not the light.
That's
you're
not.
looking
Let
for.
there be
We're
light.
talking
Let there
about
be light is different.
sunlight here.
Correct.
Okay.
So if you can eat in an 8 or 10 hour window.
Sunrise to sunset.
Yeah.
Mm-hmm.
I would.
That's ideal.
I would love an 8 to 10 hour window. 8 would be ideal. 6 is even better.
Okay.
I do a 16-8 every day. So
16 no food.
16 no food, eat 8-hour window.
Got
I'm also on Rappa, right? So
Same.
So I
do both of those,
I do rapamycin, which is probably a whole other episode. So we don't have to go into that. But that is basically a fasting mimetic, right? So when we talk about,
Right.
I mean, one of the things that it does, right, is it helps increase autophagy, right,
Okay.
through mTOR. So, but that's
So senescent cells,
Yep.
we want to get rid of them. The ideal way is autophagy. Autophagy, and that's best done through fasting.
Yeah, and the word autophagy means to eat itself.
Oh, okay.
Yeah, so our cells will eat those cells and recycle their components and their peptides and their proteins and
Make good use of it. It's a
Right.
recycling process.
Correct.
Okay. Is there another way to get rid of them? Because I'm really not going to fast. Is there another way to get rid of
And
these
we've already,
things?
so
Exercise.
not going to fast, not
Okay.
going to cold plunge.
Right, and I'm going to eat in the dark. Okay. No, the cold plunge scares me, but that's a way to get rid of the cells.
hormesis, anything hormesis. So hot sauna would be great.
Hot sauna.
And we can take a deep dive there. Yeah, how hot for how long and how many days a week, right? There are great studies on this,
Right.
mostly out of Finland. Cold plunge, we got fasting, HIIT exercise. All these things are hormesis.
Okay.
A slight stress on the body to build that resilience. That resilience comes through, killing off your senescent cells.
Is there a way to measure how many someone has and whether they're getting rid of them at a consistent rate?
There are markers. I mean, there probably are some, cell tests you can do and blood tests.
Is there a way to know you've got more than he does?
There probably is. I don't know. I don't think there's a test I can order from your lab, like a doctor's clinical test.
But they're working on it.
They are.
Yeah.
So
This is coming.
Yeah, I mean, the senescent stuff has been sort of in the background in the longevity world for, I don't know, 5-6 years, as far as and it's just now coming to the surface
Okay.
as being, a
Important.
hot thing to talk about.
Important, yeah.
And so they have been talking about trying to get some sort of test out there to measure that. But again, they don't really know, what's normal.
Yeah, what are we measuring?
Yeah,
Yeah,
right.
yeah. We're not
what's
counting
the stick?
cells.
How long's the stick? We don't really
well,
know.
like any
Right.
lab test, though, they take 1,000 people and
That's
you do
right.
the test and these are healthy people, and then you take 1,000 not healthy people and you start to create some norms, and that's how it'll happen, because these cells do leak certain proteins that aren't supposed to be out there.
Got it.
We know, and
Yes.
So I can measure the proteins that are not supposed to be in
right?
you
They're
and
leaky.
know.
They're leaky.
Yeah.
Well-
so you've got a bunch, and I know that from the test that shows all sorts of leakage occurring from these bad cells.
Right.
Got it. We did her, and she's got none. And that's how they're going to come up with this test, right?
Right.
Okay.
The other thing, the other thing-
establishing that baseline, because we
Yeah.
don't know yet.
Yeah.
Sorry, I'm just going to talk over everybody.
No, go.
The other thing I was just going to mention is, and the reason that the GLP stuff is so important, is that fat cells also increase those senescent cells.
Oh,
right? And
the more of those you have, the more senescent
it's
you're going to
bad,
have.
right? It's sort of like everything kind of feeds off, so it ends up with this horrible. It's like throwing the baby out with the bathwater kind of thing. Like you just don't. You don't want
So the Ozempic, back to Ozempic. So that's still going to help us with the senescent cells.
It theoretically, right, since we don't know all the mechanisms of action, it
Right.
theoretically should, right?
Wow.
If it's lowering your fat content
Yeah.
in your body, your fat percentage,
Right.
you should have less senescent
It
cells.
may be indirect, but
Correct,
you're right.
yeah.
Yeah.
That's amazing. There's so many correlations with that one solution.
Just stay in shape and don't be overweight, and you're fine.
Right.
Keep
It's that
moving.
easy. We
Yeah,
can end the
I know.
podcast now.
What about these companies that are coming out that are not pharmaceutical companies, and they're producing, I'm thinking of Hims and Hers, and I can't think of all the names, but there's these companies that are promoting themselves on Instagram and all these social media where they're saying that we are a GLP-1 provider.
Yeah.
Are they?
Well, yeah. I mean, they're a national telemedicine,
So they're getting these
bank.
drugs from a pharmaceutical company.
Yeah.
They're not giving us some made up.
No, I don't. I hope not.
We think these are all. I mean, I'm not speaking for all of them, but These promotions we're seeing are not fake medicines.
I've seen some of those. You see, take a pill. It's just like Ozempic. That's probably not going to work.
Okay, but we need the injection. It needs to be prescribed.
Right.
Even if it's from a telemedicine type company.
Right. But I mean, listen, we're in a immediate gratification society, and if you can on an app, text a doctor and get a prescription for a GLP-1 and that suits you, then that's a method.
Mm-hmm. Yeah. Okay. But it needs to be a legitimate GLP-1 because those are working.
Yeah. I mean, listen, some of these are generic now. That doesn't mean they're illegitimate.
And generic would be?
It's called semaglutide if it's the Ozempic, or tirzepatide if it's the Mounjaro version.
Got it. What's the new one coming out? And it may be from Johnson & Johnson, but one of the big pharmas is coming out with a new one that I think has the 3 receptors.
Right.
Do we know the name of that one?
I don't know the name. I'm sure it's out there. It's
coming.
Not on my radar yet.
Got it. Let's talk, if we could, and we're getting close to the end here, but I need to understand stem cells.
I disagree. We're at the beginning.
We're
scratching the surface.
I think we talked about 17 hours, didn't we?
Right. We're in hour 16. Stem cells. This seems like such a hot topic right now, and I know your practice really focuses in on stem cells. Tell us what they are and why they work.
Well, listen, we have had stem cells for, since we are a species, right? We are created by stem cells.
Mm-hmm.
Okay.
We use stem cells to help us grow and develop, and they're in our growth plates. And then we use them to maintain and heal and repair until they're just not working as well.
Okay.
And the faster you age, the more inflamed you are, the more inflamed and less functional your stem cell capability is.
Okay.
And if you can maintain those through all the things we talked about here, you will, and the easiest way to maintain them is to use your muscles and keep moving. 2 things correlated with longevity are muscle mass and bone density, and we scratched the surface on DEXA, but
DEXA measures the bone density.
That's one of the things. In fact, that's the most popular use of DEXA.
Right.
And if you maintain your bone density, and what's in your bone density is your bone marrow, and what's in your marrow? Your biggest store of stem cells.
Okay.
So if you keep moving, you're maintaining your stem cells. Okay, so keep moving. Anyway, those cells are important to us. They can help repair and divide and replace tissues. And you're making new skin cells all the time. For example, we can see that.
Yeah.
But we're doing that on the inside as well. And if you hurt yourself, if you have to repair a bone fracture or something else, you're calling for those cells. Mm-hmm. And the whole focus of regenerative medicine is to take that knowledge, which we now have a lot more of, and use it strategically for people with problems.
Okay.
Yeah.
Acutely.
And
when you
for
say
longevity.
Strategically, you mean in acute injuries.
It could be for chronic things too.
Okay. Let's
Let's
go through a scenario. Let's say I've got a disc issue in my back. That's so common these days.
Right.
I've got a disc issue, and I come to you. Is a stem cell treatment one of the options?
In my office, it would be, but I want to make sure we don't get in any trouble today. So let's be clear.
Don't do that.
I'm not allowed to make any marketing claims that stem cells or any regenerative biologic can cure or treat a disease or condition, because the FDA says I can't say that.
Got it.
I can tell you success stories. I can tell you how it can help your body repair, because your body's doing the work.
Yeah, but no claims.
I can't make any claims.
Got it.
Have I used them successfully for people?
Yeah.
Heck yes.
Okay. Got it. Yeah, that's an affirmative.
So you come in with your disc problem.
Yeah.
We first have to identify the exact source of the problem and the pain.
All right.
It requires a good exam. It requires to know what treatments you've been through. It requires a very high level MRI, not a regular run-of-the-mill MRI that most doctors don't even know how to order one properly.
All right.
So we get a very proper MRI because we want to match up the targets on that MRI in the bone marrow where you might have a problem, because degeneration of the joints, the discs, any joint, which we can call osteoarthritis, we can call bone on bone, we can call different things. That is a disease, a problem of the inflamed cells in the bone. The cartilage wearing down is the secondary result.
Got it.
So if I injected poison in your scalp and your hair started to lose your hair, it's not because there's something wrong with the hair, it's because there's something wrong with the cells that make the protein that's called hair.
And we're not talking about Botox here, right? We're injecting things.
We are not talking about Botox today.
Just checking.
We can, but we're not talking about that today. So circling back, we look for those bone targets. We want to help the degenerative cells that made that disc in the first place, and they live in the bone. Okay. They're called chondrocytes. They produce
live
cartilage.
in the bone nearby the injury?
Just at the edge, called the subchondral bone.
Okay.
And that's the spot that needs the love.
That's where my MRI would be. That's what would inform you where the degenerative issue originated.
Correct. And sometimes it shows us certain areas, and those are exactly where we want to inject the regenerative biologics, which stem cells is one form. There are other forms, from PRP on up.
Are there different kinds of stem cells that you can use in the treatment? Because I know there are different kinds of stem cells, but I don't know.
There are.
Currently, all we have accessible to us are what are called mesenchymal stromal cells, which are basic cells that deal a lot with the structural tissues and the organs of the body. We don't have access to other types of cells that have to be carefully curated out. Some that deal with the nervous system, some that deal with other types of tissues, because the vast majority of our body is made of these mesenchymal cells. And don't get hung up on the words, but those are the most common. And they come from two sources. I want to just interpose. One is we can take them out of your own body, but I don't know about you. When
that's very dependent on your own state of health too.
It always is.
Right.
It always is.
And so your results are going to be not consistent.
Agreed. So if you're unhealthy and elder, your cells aren't working. They would have fixed it in the first place. You wouldn't need it. But a lot of people have their own cells taken out. But when I take my car to get the oil changed, I don't put the old oil back in.
Right.
Yeah.
I like the donated, and it's ethical and it's moral, donated from the amniotic birth product. So here's your baby, ma'am. Congratulations. C-section went well. Great. Hey, by the way, this stuff you were going to throw out, can we keep it? And
could I start charging for that if I have another baby? I would like to charge.
You cannot do that. Actually, a true donation has to be from the heart. So you cannot charge for that. So it's donated. It's screened by, ironically, FDA compliant labs, certified labs. Screened, tested, make sure it doesn't have any problems, diseases, what have you. And in fact, the sources that we use, the mothers have not been vaccinated for COVID, and that, although that could be
that's hard to find.
It could be a political statement, but it's not meant to be. It's just we just don't know enough.
Yeah,
and we're
how it could affect the cell.
Sure.
Correct. Yeah. So we're not doing that, and they're screened as early as the first trimester.
Do we know if the cells are Democrats or Republicans?
You promised this wasn't going to go political.
No, it's not. I just need to know if we can tell.
We just want to know if we're getting injected with blue or red.
Right.
No, you
wouldn't know that.
We don't know that. There's no pollster in
that. No hanging chads.
Right.
That's right.
Now,
it's agnostic.
if a woman is going to give birth and meets these criteria, is that something she could also save for herself if she wanted to use
100%.
those?
Oh, that's a great question.
So that's something preemptively that women could start planning for. As far as being able to use that.
In fact, if 20 years ago you've donated your umbilical, or not donated, if you stored or banked your umbilical cord cells, you can now use those for other purposes than for which they were originally banked, which was, God forbid, your child has leukemia, you need a whole bone marrow replacement. They can now be used for other purposes and for family members.
Wow.
So that's being expanded as well.
So is a stem cell a stem cell a stem cell?
No, I'm sure they have different qualities and factors depending on the health of the individual, as you alluded to.
But I've got the back issue. I'm in your practice. I'm wanting you to fix me. Aside from a non-COVID stem cell, what else?
We're going to go one better. We're going to one better.
Tell me.
If I give you stem cells today in your vein, they'd be gone in 10 to 14 days. But the benefits might last weeks or months, or even repair something that lasts much longer.
Okay.
Why is that? Their cells are gone. Well, it turns out those stem cells communicated with your cells, and your cells are doing the work.
Okay.
And that communication is by proteins, peptides, and growth factors, and small, not that cells aren't already small, smaller particles called extracellular vesicles, or for short, exosomes. Heard of that?
Yep.
And stem cell-derived exosomes are really the business end of the stem cell doing most of the work. We can now skip the stem cell and go right to the exosomes, which has some advantages. One is it's less than half the cost because they're more abundant, because they come from the amniotic fluid, and there's so much amniotic fluid. They get concentrated down is another one. They penetrate tissues better.
Wow.
They can cross the blood-brain barrier. They're wonderful.
Okay.
So they're easier to store and handle.
You're injecting these?
I'm injecting
into my veins.
That's one way, but for your back?
Yeah, my back.
It's going right into the targets we saw in the MRI.
In the bone.
Into the bone.
Okay. Are you getting to the bone marrow with this stem cell injection?
I am.
That sounds like it hurts.
That's deep. It's like an epidural.
It's deeper.
Yep.
That's why we do it with twilight sedation, not general anesthesia. You're not asleep. You're just you don't know. It's like a colonoscopy.
So you're going with a hardcore needle deep into the bone.
Yep.
That's the target of my back issue.
Correct.
Interesting.
Is there any rejection?
No. First of all, stem cells is only hypothetical that they can be rejected. I have never seen that. But exosomes have really minimal, if any, markers on their surface.
They're sort of agnostic.
They're completely agnostic.
Okay.
Yeah, they're not voting for anybody.
They're part of the army. They're part of the army that's going to do the work.
They're doing the work. They're the ones. They deliver heat shock proteins and peptides, and they switch your cell into an anti-inflammatory, healing, restorative, youthful mode, as if you've been exercising, doing a hot sauna and cold plunges. It's your cold plunge.
Okay, let's stay here for a second. Why does my body?
With it.
Why does my body want to receive it that way? What's happening in me that's meeting your exomes and says, "Hey, look, let's party. Let's fix this situation now." What's happening? What are those exomes doing to my cells that say, "Let's get to work"?
Your body has been exposed to a number of decades of
degeneration
from the world, from what's in our food that shouldn't be there, from pesticides, what's in the water, what's in the air, electromagnetic
no-hit
fields,
exercise,
neurostress, bad thoughts, all that. So the low-hanging fruit would be exhibited. Like the first things you'd see with inflammatory problems would be an autoimmune problem, skin, psoriasis, and joint degeneration.
So I've got lethargic, lazy cells that are meeting your energetic exomes.
Correct. The exosomes are delivering a signal to the genes and the ribosomes in your cell. The ribosomes will make proteins that those exosomes tell them to make, which are anti-inflammatory, which means they are optimal mode. They are restorative. They will tell your genes to stop making all these defensive, cranky, but the electromagnetic fields, no. Get into the youthful restorative. It's telling the factory to make cartilage that it used to make, and it made that joint in the first place.
Okay, how many exomes? This sounds like quite the meeting they're having inside my body.
They are.
So how many of these exomes are required for this meeting to be successful?
We usually get it done with one application.
One injection.
That's pretty efficient.
Right.
And is there a level of lethargy, that's the only way I can think about it, in my cells that just, we don't care what you send down here. We've had enough. We're wore out.
It's possible. I haven't encountered that yet.
But
the more degeneration you have, the more cartilage that's worn away, the longer it takes. But listen,
You mean the longer it takes for it to kick in?
To the repair, yeah, because it takes months, right? I have a very good friend, and he has what's called grade 4, which out of 4, degeneration, which is bone on bone in his knee.
Yeah.
And we injected his knee based on the targets. And he called me about 3 months later. He goes, "Yeah, I'm just not getting any benefit." And I go, "Well, give it time. But you know what? If you're concerned, let's get an MRI." We got an MRI. He had 30% increased height of his meniscus.
Wow.
And I said, "Listen, it's happening."
It is happening.
And about a month later, he goes, "You know what? I can walk up the hill now." I wasn't patient. I wasn't patient. I go, "That's all right. Neither was I."
Is there an age at which this sort of So even if you're 85 or 90?
That's the question.
Sometimes we get even more exciting results the more degenerated you are.
Because the expectation's so low.
And think about this, why is this called regenerative medicine? Because we're degenerating, and the opposite of degeneration is regeneration.
So what kind of cost is that?
That's a great question.
If he's walking in and he's looking for the thing, is that a $1,000 thing? Is that a $10,000?
No, what's this costing me?
I'd say you usually do, like a knee, for example, if it's just a localized spot, we do one above the cartilage, one below. So it's 2 doses. And my big costs are the doses and the surgery center with the anesthesiologist and all that. So you're looking at, give or take 10,000, something like that.
So cheaper than a knee replacement.
Yeah, but people will say, "I have insurance that's going to cover that," but they're not. "Oh, I'm going to miss 3 months of work and all the pain and the physical therapy and the risks and the narcotics."
And this is not typically covered by insurance yet.
It is not yet, and I'm glad you said yet, because PRP, which
platelet-rich plasma,
you take out of your blood. You said it right, and spin it down and use it for certain things, and it can be used for these purposes as well. Is also not approved for claims by the FDA for marketing. but many insurances have figured out
that it
it's
works.
cheaper than surgery,
Right.
and they're starting to pay for it. So I think it's coming. Also, Big Pharma's getting its hand in this stuff. It's coming.
Sure.
There are people who don't want this to come, and those people make knee implants and spine hardware, and drugs and cortisone shots and things like that. Yeah.
What about preventative?
Yeah, but we have a couple different things. People who have had like a knee scope, their knee is doing great, but they will have accelerated degeneration from the trimming and removing of some tissues. So we have done some athletes that want to stay ahead of it or have maybe a little click or ache and pain, a lot of different things. So we can do it. I mean, it's an investment for that.
Sure.
But, yeah.
Okay, I want to wrap up this episode with this question that we started with. This new article that's come out that says that aging, you could go to age 44 and not show something. You could look 25. And all of a sudden at age 44, there's something visible occurring that people know, wow, you're getting older. So what's happening in the body, this accumulation of aging that doesn't seem to show, and then at age 44 and somehow at age 64, these two ages matter. Is that true? And why are they saying this?
Yeah, I mean, we all saw the paper, right? I mean, and these are observations and patterns. And
did you agree with the observations?
Yeah, I mean, I can't not agree with them, right? Okay. It was well done. So and you look back and go, yeah, I guess that kind of makes sense. When I started hitting 40s, I needed reading glasses and this and that, I started thinking about Botox. And so, why is that? Are our telomere lengths changing at that point? You reach critical mass. And not everyone's exactly the same age, right? This is
it's a continuum.
It's a peak of
it could
data.
Be 47.
Yeah. So I don't know that they had some theories. I don't know that we know why.
Yeah.
But like anything in biology, it starts with observations, and then we try to explain it back from there.
Yeah. But you guys saw the articles. You agree with it?
Absolutely. Well, I mean, I'll tell you. So I just turned 45 on Tuesday.
Yeah.
Right.
Happy birthday.
Thank you. And don't feel a day over 30. But I will tell you that in the last 2 years, and I'm a very active guy.
Yeah.
Right. The last 2 years, there have been some things. Right. Broke my toe. Right.
Yeah.
Ripped my tricep.
Yeah.
I can tell that there are just some things that are different. Maybe a little bit less for me than for some other people, just because of my activity level and everything that I have going on in my protocols. Right. But I would say that from the people that I coach, the people that I'm around, I can say anecdotally, 100% agree.
It's happening. Mm-hmm. So someone at age 64, it's not strange for their kids to visit them. Maybe they haven't seen them in a little while and say, oh, God, Dad's getting older. And it would be noticeable. Wow. Is it happening internally as well as externally?
It has to be. Yeah. Same cells, same born on date.
Wow. Interesting. Guys, this has been fabulous. Really fabulous.
Fun.
Yeah, and we need to do it again for sure. I want to make sure that the audience knows how to find you. So why don't Josh and Janae tell us again how we can best find you through Instagram, the actual website?
Sure. So on YouTube, we are the Becoming Young podcast.
Great.
We also are online on becomingyoung.io.
Becomingyoung.io?
Yes, that's
Great.
where our program is, so you can find us there.
And you two are both very dynamic and so well informed about this subject. I just want to thank you for being here today.
Thanks
it's been
for having
great.
us.
I will talk about this all day long. So anytime that you want to give me a call, I will talk about it until I'm blue in the face.
Great. Thank you for being here. Dr. Gross, this is so good to have you here.
Thank you. And
Tell
thank
us
you
how
guys for doing this together. Yeah.
How can we find you?
You can find me at recelebrate.com and Instagram at recelebrate, because we're celebrating the renewal of our cells.
Yes.
And I'm doing that through regenerative medicine mostly, and that's RECELLEBRATE.
Great. And that's both Instagram, website,
LinkedIn, Facebook, etc.
It's everything.
It's all over the place.
And you guys are all speaking everywhere on these subjects. I really appreciate you taking the time to be here today. Thank you.
Yeah.
Thank you.
Thank you, James.
This has been another episode of Inside Out. We'll see you next week. Thank you.